Welcome to Kaleida Health Medically Speaking and our special series on the fight against the coronavirus. As you can see, we have modified our format to practice safe social distancing while providing timely and factual updates from the Kaleida Health team during this public health crisis. We as a healthcare organization believe it's important for the Western New York community to hear from our medical experts who are leading the charge in our facilities and with our workforce of over 10,000 strong. I'm Mike Hughes, and this is Medically Speaking. Dr. Jamie Nadler is an intensivist at the Buffalo General Medical Center and one of Kaleida Health's leading experts on the fight against coronavirus. Dr. Nadler, thanks for joining us today.
Thanks for having me.
So if you can, tell us a little bit about your role with Kaleida Health in the current crisis with the coronavirus and how you've been lending your expertise to this.
Yeah, so twofold. One, obviously managing patients in our medical ICU as they come in. The other role has been helping strategize around clinical pathways, getting patients enrolled in studies and getting them all the experimental therapies or off-label use medications that we can to try to improve their outcomes here at Kaleida.
So talk about the intensive care area of the organization right now. That's obviously a heavy focus with this type of disease and this issue. So why does the intensive care unit become such a focus?
It seems like the pathogenesis of this disease, patients are rapidly deteriorating. They come in with somewhat mild symptoms from the community, and those who are going to progress quickly. They progress to the point that they need to be put on life support, in particular ventilators and needing to support their oxygenation levels. So most of those patients are in the ICU on pretty high level of life support. And the bulk of our patients that aren't sent home within the first few days are ending up in the medical ICU here at Buffalo General.
But, that being said, we have discharged a number of patients, since the virus broke out. Do you have a percentage of how many have been discharged versus how many are still being treated?
Yeah, I would say the majority are discharged. I can't give you exact numbers. We have also had some excellent success stories of discharging people who were, on full life support that we've been able to get off the ventilator, sent to the floor, and have actually been discharged home. So despite the short time course of this in Erie County and in Buffalo, we have had some excellent success stories. But you are correct. The bulk are coming into the floors being treated and sent home.
So as difficult as the issue is and as problematic as the virus has been, there is some hope in terms of treatment and for patients to have a recovery?
Absolutely. Even with just supportive care, we're seeing some turnaround in these patients without any of the medications that everyone's hearing about in the media. Just getting them through the hump with their low oxygen levels seems to help.
So Dr. Nadler, you mentioned medications. Let's talk about that for a minute. There isn't a defined cure for this, so to speak. Organizations like Kaleida Health and others have had to rely on trial drugs and experimentation to help fight through this. So if you can, tell us a little bit about that.
Yeah, you're absolutely right. There's no cure. I think the hope long-term is that we'll have a vaccine which will help with this. It's similar as we do with the flu. There are some experimental therapies. In fact, they're all experimental at this point. There are 5 that we're looking at, or 4 within our institution in particular. The one that everyone hears about on the news is hydroxychloroquine. This is an anti-malarial drug that's used for other inflammatory conditions. So we are giving it to our patients right now, particularly starting if they're on the mild, moderate spectrum to help prevent them from getting to the severe disease. But we are using that medication. The one that's often used in conjunction with that one is a common antibiotic called azithromycin, what people in the community might know as a Z-Pak. It's being used because it has some potent anti-inflammatory effects in addition to its antimicrobial effects. So the hope would be to shut down the inflammation while the Plaquenil potentially fights the virus, and those two in combination may be helpful. A third drug that we just started using this weekend and as part of a trial is a drug called Sarilumab. It's what we call a monoclonal antibody. It's an antibody that fights a particular cytokine that leads to a lot of inflammation. What we're seeing with this disease is once you get infected, your immune system starts revving up, you get a lot of inflammation, and then you start having complications from the inflammation independent of the actual viral infection. So the thought would be to shut down that inflammation, and that would help expedite people's recovery. The fourth drug, which we don't have access to yet, is called remdesivir. It's an antiviral drug that was initially developed to help fight Ebola. Seems to have activity against coronavirus. So the hope is that it will help us expedite recovery by having antiviral activity. And the fifth one, which is the hot topic, is the convalescence serum. This is something being spearheaded by Oscar Gomez at OCH. The idea behind this is patients who have been exposed to the virus and fully recovered have developed antibodies against the virus. We would take their serum and transfuse them into critically ill patients, and the antibody could potentially fight that virus. It does require that patients be symptom-free for at least 14 days after they've recovered, so we're not transfusing the virus with the antibodies, and enough patients to actually get enough plasma to use for transfusion with patients. So that is something we're working on right now. The FDA has given us the okay to use it as an experimental treatment. We're just working through IRB and our ability to collect the plasma in order to give it to patients. So hopefully that's coming pretty soon down the road. There has been success in the past using this against other viruses, particularly when you look at SARS and MERS, which are also coronaviruses. There was some varied success using this method with those two infections. So our hope is it'll be useful with COVID as well.
So you have 5 different options that you're working through. Not every single option works for each patient. Does it depend on age and demographic, or does it depend on comorbidities or the current health status? How does one get defined treatment?
Yeah, it's a little different for each one. So for example, the hydroxychloroquine and the azithromycin, as I mentioned, there could be side effects when you use them together. So our screening is more based on avoiding giving it to a patient that could have a complication from it as opposed to the actual indication. For the monoclonal antibody, the shutdown infection, what we are looking for is signs in their blood that they are systemically inflamed as opposed to just having the infection. If you just have the infection and you have mild disease without signs of systemic inflammation because of potential side effects from the drugs, we're going to avoid giving it in that scenario. For convalescence serum, we're really reserving that for the sickest of the sick patients in the ICU. That's really will be our entry criteria. And the remdesivir, our hope would be to just be able to give it to anybody who has confirmed COVID infection, as long as they don't have a contraindication to the drug.
So Doc, you mentioned a multidisciplinary team earlier. If you can, give a shout out to your ICU colleagues and those across the organization, not just within that department, but elsewhere, that have helped manage through this.
Absolutely. We have a wonderful team here at Kaleida. We have a group of medical intensivists who are managing patients on the front line. Obviously can't do it without the help of our nursing staff who are in and out of those rooms, managing the patients, not giving a second thought, exposing themselves, although they're using proper PPE. Our respiratory therapists who are manning the vents and making sure these patients are safe, oxygenating well, and our clinical pharmacy team who rounds with us every day and is helping us make all the decisions about the medications that we give. I'd also like to say a special thanks to all the non-intensivists who are helping us, the surgeons, the anesthesiologists, the pediatric critical care folks, the cardiologists who have all stepped up and offered to help manage these patients when we get overwhelmed. We will probably be leaning on them heavily, and we appreciate their support.
Well, Doc, thank you. Thank your colleagues on behalf of a grateful community. We thank you for joining us again today.
Thank you.